All right, so hey everyone listening, ready for another deep dive? Today we're tackling something you're bound to see on your MCCQE pneumonia. And I've got, well, I don't know if resident is quite the right word, but our expert is back. You know who it is.
Haha. I've reviewed enough of those exams to last a lifetime, that's for sure. But listen, we're here to break down pneumonia, especially the kind that can really throw you for a loop when it hits those who are, immunocompromised.
You got it. No more just memorizing facts and figures. We're going deep, pulling out the stuff that matters from sources like, stat pearls.
Think of us as your, well, maybe not Sherpas exactly, but we'll guide you through this tricky pneumonia terrain, especially, like we said, when it pops up in immunocompromised patients.
Before we jump in, though, just a quick reminder, we're not giving medical advice here. This is all about prepping for the exam. Always talk to a real doctor for, well, real medical stuff. Okay, disclaimer done. Let's dive in. What is pneumonia like, really, and why is it such a big deal in the MCCQE?
It's not just a cough, right? Pneumonia, it's an infection that goes after the lungs, specifically the parenchyma. That's the tissue where the gas exchange happens. And it's not just one bad guy causing all the trouble. Oh no. We're talking about a whole bunch of different organisms that can be behind this. Bacteria, viruses, fungi, even parasites sometimes.
So pneumonia, it's more like a general term for a whole group of infections, right? Like, I remember learning about all the different types, like community-acquired, hospital-acquired, and what about the one that people on ventilators get?
Yeah, you're on the right track. And here's a fact that might surprise you. Less than 10% of the time can doctors figure out one single cause for pneumonia. That's why diagnosing and treating it can be a bit of a puzzle.
Okay, that makes sense thinking about all the different bugs that could be involved. So today we're focusing on pneumonia in, like we said, immunocompromised people. It's a big topic for the MCCQE, and even more importantly, for your future patients, right?
Absolutely. As doctors, you'll be seeing patients with weaker immune systems, making them more susceptible to infections, especially those affecting the lungs. So yeah, understanding pneumonia in this context, it's super important.
All right, let's break it down a bit. Some people might be wondering, immunocompromised, what does that even mean?
Basically, it means their body's defense system, the immune system, isn't working as well as it should. There are tons of reasons why this could happen, like HIV/AIDS, cancer treatments, organ transplants that need those immunosuppressant drugs. Even certain medical conditions can weaken the immune system.
And because their defenses are down, they're more prone to infections that wouldn't bother a healthy person, right?
Exactly. And here's the kicker. They're not only susceptible to the usual bacteria, but also to what we call opportunistic pathogens.
Opportunistic pathogens. Sounds kind of sneaky.
Yeah, kind of like those friends who only call when they need something. They're usually just hanging out, but when they sense a weak immune system, bam, they take advantage and cause infections that wouldn't normally happen in someone with a strong immune response.
So pneumonia in the immunocompromised? It's a whole different ballgame.
You got it. Knowing who the players are is essential, both for the MCCQE and for taking care of your patients.
So let's start with, like, the usual suspects. The bacteria we all remember from micro, like Streptococcus pneumonia, Haemophilus influenza, and Staphylococcus aureus.
Ah, yes, the classics. But even these guys can act differently in someone who's immunocompromised. An infection that might cause a mild pneumonia in a healthy person can become a lot more serious, even life-threatening, in someone with a weaker immune system.
So it's not just about recognizing the names, but also understanding how these bacteria can change their game plan in a, vulnerable host.
Exactly. And then there are those less common but potentially more dangerous opportunistic pathogens that take advantage of a suppressed immune system.
Okay, I'm all ears. What are some of the major players we need to know for the MCCQE?
Well, when it comes to pneumonia in the immunocompromised, there's one fungus that's a real standout pneumocystis jirovecii, usually just called PCP.
PCP, right. Didn't we get a handle on that with better HIV treatments?
You're right. It used to be a defining feature of AIDS. Prophylaxis and antiretroviral therapy, or ART, have made a huge difference in HIV-infected populations.
So, not such a big problem anymore.
Well, hold on. It's less common in people with HIV, but PCP is showing up more in other immunocompromised groups, those on immunosuppressants after transplants, people with certain cancers, and others with suppressed immune systems. It's like the fungus has shifted its focus, which makes it even more important to understand.
That's interesting. So how does this PCP spread?
It's airborne, person to person, often from people who don't even have symptoms. Those asymptomatic carriers, they can be tricky. And here's a little tidbit. PCP mainly hangs out in the alveoli, those tiny air sacs in the lungs.
But what if someone's immune system is really weak? Could it? Like,
You're thinking like a doctor already. Yes, in severely immunocompromised people, PCP can spread beyond the lungs, causing what we call extrapulmonary manifestations. So you might see infections in the lymph nodes, spleen, even the brain.
okay, so we've got this potentially serious fungal infection, especially in immunocompromised people. But how do we know if someone actually has it? What signs should we look for?
That's where it gets tricky. Diagnosing PCP, it takes a combination of things. Clinical suspicion, a good patient history, and the right lab tests.
So it's not as simple as just looking at a chest x-ray and saying, yep, that's PCP.
Unfortunately, no. And to make it even more complicated, getting a definitive diagnosis can be tough, especially in those who don't have HIV. They tend to have lower levels of the organism, making it harder to find.
So what symptoms should make us think of PCP?
Well, you often see the typical pneumonia symptoms, fever, cough, and shortness of breath. We call that dyspnea, of course. But how these symptoms appear can be different depending on whether someone has HIV or not.
Oh, interesting. What's the difference?
In people with HIV, PCP tends to develop slowly. You might see a dry cough that hangs around for weeks, a low-grade fever, and shortness of breath that gets worse over time. It's sneaky, like a slow burn.
Okay, so a slow burn with HIV. What about folks without HIV?
It can be totally different. They might suddenly have severe breathing problems like someone flipped a switch.
Wow, that's a big contrast. So if we suspect PCP, do we wait for all the tests to come back before starting treatment?
Absolutely not. Time is critical, especially for those who are high risk. If we suspect PCP, we need to start treatment right away, even without a definite diagnosis. It's always better to be safe than sorry.
Yeah, that makes sense. You don't wait for a fire to get out of control before calling the fire department. So what's the go-to treatment for PCP?
The first-line treatment, the gold standard for both HIV and non-HIV patients, is a combo of two antibiotics, trimethoprim and sulfamethoxazole. We often just call it TMP-SMX.
TMP-SMX, got it. But what about those sulfate allergies? Seems like those are pretty common.
You're right, they are. If someone's allergic to sulfa, we have to look at other options, although they might not work as well. Pentamidine and primaquine are possibilities, but they come with their own side effects. And for severe cases, we might have to use intravenous pentamidine.
Okay, good to know we have backups. So, first-line treatment, backup options, anything else we need to think about when treating PCP?
Now, this is where it gets a bit tricky. For moderate to severe cases, we sometimes add corticosteroids like prednisone to the mix.
Steroids. But wouldn't those suppress the immune system even more? That seems counterintuitive.
You're sharp. Yes, steroids can suppress the immune response, but in this specific situation, the benefits outweigh the risks. Corticosteroids work by reducing inflammation in the lungs, which can really improve outcomes. They can even be life-saving.
So it's about finding the right balance, using steroids strategically to calm the inflammation while also fighting the infection.
Exactly. It's a delicate balance, and we decide whether to use steroids on a case-by-case basis, considering how severe the infection is and the patient's overall condition.
It sounds like managing PCP takes a lot of careful consideration, understanding how the immune system, the infection, and the medications all interact.
You're absolutely right. And on that note, let's talk about preventing PCP in the first place.
Oh.
Can we even do that?
Yeah, I'm curious about that too.
Prophylaxis is key, especially for high-risk groups. We're talking about those on long-term glucocorticoids, folks receiving immunosuppressive therapy after transplants, and those with very low CD4 counts, like below 200 cells per microliter.
So for these patients, taking preventive medication is like adding an extra layer of protection.
Exactly. It's like reinforcing their weakened defenses. But there's a little caveat here. If someone's already taking pyrimethamine sulfatazine for toxoplasmosis, we usually don't add PCP prophylaxis on top of that. It's like getting two birds with one stone.
Got it. Seems like managing PCP involves a lot of careful balancing, considering the patient's individual situation and weighing the risks and benefits.
That's the essence of medicine, right? Now, before we move on, we need to talk about what can go wrong with PCP. It's not always a smooth recovery, unfortunately.
Yeah, we haven't even touched on the potential complications yet. What are some things we need to watch out for?
Well, PCP can lead to some pretty serious problems, just like any pneumonia. Pneumothorax is one that's when air leaks into the space between the lung and chest wall, causing the lung to collapse. In severe cases, it can even lead to respiratory failure, which means the patient might need a ventilator. And sadly, some patients don't survive, even with the best medical care.
That's a sobering thought. Are there any factors that make someone more likely to have a bad outcome with PCP?
Definitely. Age is a big one, as is the degree of hypoxia. That's how low their blood oxygen levels are. Previous episodes of PCP also increase the risk, as do any other lung problems they might have. It's kind of like a domino effect. The more health challenges someone has, the harder it is for their body to fight off this infection.
Okay, so TCP is a serious infection, especially in those with weakened immune systems. It sounds like understanding its nuances is really important for both the MCCQE and our future practice.
You hit the nail on the head, but hold on tight. We're not done yet. This is just the tip of the iceberg when it comes to pneumonia in the immunocompromised.
So, what's next on our deep dive agenda?
Well, next time we'll expand our lineup of microbes, talking about other opportunistic infections that can cause pneumonia in those with weakened immune systems. We'll look at their unique presentations, the challenges in diagnosing them, and how to tailor treatment for the best possible outcomes.
I'm already intrigued. So, everyone listening, be sure to tune in for part 2, where we'll continue exploring pneumonia in the immunocompromised. It's going to be a wild ride.
And remember, this is just for information, not medical advice. Always consult a qualified healthcare professional for any health concerns.
Until next time, stay curious and keep those brains working. All right, welcome back, everyone. Ready to dive back into those tricky pneumonia cases? You know, the ones in immunocompromised patients.
That's right, we tackled PCP last time, that sneaky fungus that likes to, well, take advantage when the immune system's down.
Yeah, we covered a lot, but PCP is just, one piece of the puzzle. There's a whole world of other microbes out there that can cause trouble.
Exactly. Pneumonia in the immunocompromised, it's a complex landscape. And today we're going to explore some of the other major players, the ones you need to know for the MCCQE, and of course for taking care of your patients.
So who are these other microbial troublemakers?
Well, let's start by going back to those common bacteria we mentioned before: Streptococcus pneumonia, Haemophilus influenza, Staphylococcus aureus, the usual suspects in community-acquired pneumonia.
Right, the classics. But do they act differently in immunocompromised people?
You bet. In a healthy person, they might cause a, typical pneumonia. But in someone with a weakened immune system, these bacteria can cause much more serious infections, more complications, higher risk of spreading beyond the lungs.
Makes sense. It's like their defenses are down, so even a minor infection can become a big problem.
Exactly. And that's not all. Immunocompromised individuals are also susceptible to bacteria that don't usually bother healthy people.
Ah, those opportunistic infections. What other opportunistic bacteria should we be thinking about besides PCP?
There's a whole group of gram-negative bacilli that can cause serious problems. One of the main culprits is Pseudomonas aeruginosa, often found in hospitals.
Pseudomonas, yeah. Doesn't it have a reputation for being, resistant to antibiotics?
You're right on the money. Pseudomonas is notorious for developing resistance to multiple antibiotics, making it a tough one to treat. And it can cause all sorts of infections, not just pneumonia, urinary tract infections, skin infections, even sepsis, which can be life-threatening.
Wow, sounds pretty nasty. Are there any other gram-negative bacteria we need to know?
Another one to keep on your radar is Stautrephomonas multifida. Like Pseudomonas, it's known for its antibiotic resistance, and it can cause a variety of infections, especially in those with compromised immune systems. It's a bit of a theme, isn't it? Opportunistic infections, often with tricky resistance patterns.
It definitely makes treating pneumonia in these patients more challenging.
Absolutely. It's like a game of whack-a-mole. You treat one infection and another one pops up, often with its own set of challenges.
So we've covered bacteria, both the common ones and the opportunistic ones. What about viruses? Do they play a role in pneumonia in immunocompromised people?
Viruses are definitely part of the picture. They can be the main cause of pneumonia, or they can set the stage for a secondary bacterial infection, like a 1-2 punch.
So they can either be the main culprit or like an accomplice, making things worse.
Exactly. And when it comes to viruses that cause pneumonia in the immunocompromised cytomegalovirus, or CMV, is a major player.
CMV, yeah. I remember learning about that in transplant patients.
Right. CMV is often hanging around, and when the immune system is suppressed, it can reactivate and cause all sorts of problems, including pneumonia.
Like a sleeping giant, waiting for the right moment to wake up and cause trouble.
I like that analogy. And the symptoms of CMV pneumonia can be all over the place, from mild flu-like symptoms to severe breathing problems. It can be tough to diagnose.
It sounds like it. How do we even figure out if someone has CMV pneumonia?
It takes a bit of detective work. Clinical suspicion, lab tests like blood tests for CMV DNA, and sometimes more invasive procedures, a bronchoscopy where we look directly into the lungs, or even a lung biopsy.
Wow, that's a pretty extensive workup.
Yeah.
What about treatment? Are there specific antivirals for CMV?
Yes, thankfully. We have a few antiviral medications that are effective against CMV, like ganciclovir, valganciclovir, and foscarnet.
Good to know. Okay, so we've talked about bacteria and viruses. Anything else?
Oh, can't forget about fungi. We talked about PCP, but there are other fungi that can cause pneumonia in people with weakened immune systems.
Okay, hit me with some more fungal facts.
Well, aspergillus is a common one, especially in patients with prolonged neutropenia. That's when the neutrophil count is low, which means their ability to fight off infections is really compromised.
So Aspergillus sees this opportunity, low neutrophils, weak defenses, and takes advantage.
Precisely. And it can cause a range of lung infections, from simple allergic reactions to a very serious condition called invasive aspergillosis. That's when the infection spreads to other organs and can be life-threatening.
Invasive aspergillosis. Yeah, that doesn't sound good. How do we treat that?
Antifungal medications are the mainstay of treatment for invasive aspergillosis. We have several options, including voriconazole, amphotericin B, and the echinocandins. The choice depends on a lot of factors: the specific fungus, the severity of the infection, the patient's overall health, potential drug interactions.
This is all fascinating, but I gotta admit, I'm starting to feel a little overwhelmed. So many different pathogens. How do we even begin to approach a patient with suspected pneumonia, especially when they're immunocompromised?
It's definitely a lot to take in, but the key is to approach these patients systematically, like a detective. Consider their individual risk factors, their clinical presentation, what symptoms do they have, how severe are they, and the lab results.
So it's about putting the pieces together to figure out who the most likely culprit is.
Exactly. And don't underestimate the power of a good history and physical exam. Ask about their medical history, any recent travel, contact with sick people, medications they're taking.
It really is like detective work, gathering all the clues.
I love that analogy. And don't forget about imaging studies like chest x-rays and CT scans. They give us a visual of what's happening in the lungs, how extensive the infection is, if there are any complications.
Right, imaging lets us see what's going on, like a window into the lungs.
And of course, we can't forget the lab. Blood tests can show us things like an elevated white blood cell count, suggesting infection. Sputum cultures can help identify the specific bacteria, and sometimes we need to do a bronchoscopy to get samples directly from the lungs, especially if we suspect a less common pathogen.
It sounds like diagnosing pneumonia in these patients is a multi-step process, using all the information we can get.
It is. It's like solving a puzzle, using all the pieces to figure out the diagnosis. And once we have a good idea of the culprit, we can tailor the treatment accordingly.
That makes sense. Are there any general principles that guide treatment for pneumonia in immunocompromised individuals?
That's a great question. While the specific treatment depends on the pathogen, there are some overarching principles.
Okay, I'm ready to hear about these guiding principles.
First and foremost, we need to act fast. Immunocompromised individuals are more prone to rapid disease progression. Early intervention is critical.
So it's a race against time to get the infection under control.
You got it. And we often start with broad-spectrum antibiotics, covering a wide range of potential bacteria, especially if we're not sure what's causing the infection.
Like casting a wide net to catch the culprit.
Exactly. Damage control in the early stages. Then, once we get those culture results and know the specific bacteria, we can adjust the treatment.
So we start broad and then narrow it down based on the lab findings.
Precisely. We call this de-escalation. It helps reduce the risk of antibiotic resistance and minimize side effects.
So we start with a shotgun approach and then switch to a sniper rifle once we have a target.
I like that. And we need to be extra careful about drug interactions. Many immunocompromised individuals are taking multiple medications, so it's like a complex puzzle.
Yeah, making sure all the medications work together without causing any problems.
Exactly. We have to be aware of each medication, how it works, potential side effects, and how it might interact with other drugs. It's a balancing act. And finally, supportive care is so important.
Supportive care, what does that involve?
It's all about optimizing the patient's overall well-being while we fight the infection. This might mean oxygen therapy, especially if they're having trouble breathing. In severe cases, we might need to provide respiratory support, like mechanical ventilation.
So we're not just treating the infection, we're supporting the patient's body, giving it what it needs to heal.
Exactly. And supportive care also includes making sure they're getting enough nutrition. Many patients with pneumonia, especially those who are immunocompromised, might not be eating well.
Right. It's hard to focus on food when you're struggling to breathe.
Exactly. So we might need to provide nutritional support, either through diet changes or sometimes intravenous fluids or tube feeding.
Okay, so those general principles make sense. Act fast, start broad, narrow it down, watch out for drug interactions, and don't forget about supportive care. Now let's talk specifics. How do we actually treat different types of pneumonia in these patients?
Let's start with bacterial pneumonia, the most common type. For those usual suspects we talked about earlier, we typically use antibiotics like beta-lactams, macrolides, or fluoroquinolones. The choice depends on the patient, allergies, and local resistance patterns.
So we're using those standard antibiotics, but always being aware of local resistance patterns.
Exactly. Now, when we're dealing with those opportunistic bacterial infections, we need to bring out the heavy hitters.
Heavy hitters, what do you mean?
Well, like Pseudomonas aeruginosa, for example. Remember, its resistance to antibiotics. It's like a moving target, always evolving.
So how do we fight something that's constantly changing?
We need to be strategic, using combination therapy with powerful antibiotics.
So like attacking from multiple angles.
Exactly. We often combine anti-pseudomonal beta-lactams, aminoglycosides, and fluoroquinolones, each targeting the bacteria in different ways.
Like a multi-pronged attack.
Exactly. And to make sure we're using the most effective antibiotics, we often adjust the treatment based on susceptibility testing.
Susceptibility testing, what's that?
It's a lab test that tells us which antibiotics are most likely to kill or inhibit the growth of the specific bacteria causing the infection. It's like a personalized battle plan.
So we're constantly adapting our strategy based on the latest information from the lab.
You got it. Now let's talk about viral pneumonia.
Okay, viral infections. Those can be tricky. How do we approach those?
For CMV pneumonia, we use antiviral medications, ganciclovir, valganciclovir, and foscarnet.
Right, those medications work by stopping the virus from replicating.
Exactly. They halt the viral production line, giving the immune system a chance to fight back.
It's like giving the immune system a boost.
Exactly. And how long the treatment lasts depends on the severity of the infection and the patient's response. Some people might need a short course, others might need longer treatment.
So it all depends on the individual patient.
Absolutely. Now, for fungal pneumonia, we already talked about PCP. Just to recap, the first-line treatment is trimethoprim sulfamethoxazole, or TMP-SMX.
Right, and starting treatment early for PCP is crucial, especially in immunocompromised individuals.
Absolutely. Early intervention is key. And as we discussed, corticosteroids can be helpful in moderate to severe cases to reduce inflammation.
Giving the patient the best chance of recovery.
Exactly. And for other fungal pneumonias like invasive aspergillosis, we use antifungal medications. Remember orticonazole, amphotericin B, and the echinocandins.
Yeah, those are the big guns for fungal infections.
Right. The choice of antifungal depends on a lot of factors: the specific fungus, how severe the infection is, the patient's health.
It sounds like treating fungal pneumonia is really complex.
It can be, but with the right knowledge, a systematic approach, and good clinical judgment, we can manage these cases effectively.
This has been so informative. I'm starting to understand the complexities of pneumonia, especially in immunocompromised people.
It's a fascinating area of medicine, that's for sure, and we're just scratching the surface.
Well, I'm ready to hear more. What about specific management strategies for different types of pneumonia?
Great question. In the next part, we'll dive into the details of treatment, the different antimicrobial options, the role of corticosteroids, and the importance of prophylaxis.
Can't wait. Everyone listening, be sure to tune in for part 3, where we'll continue our exploration.
And as always, remember this is just for informational purposes, not medical advice. Always talk to a qualified healthcare professional for any health concerns.
All right, welcome back, everyone. It's time to wrap up our pneumonia deep dive. You know, we've gone through the whole lineup of pathogens: bacteria, viruses, those sneaky fungi, the ones that love to take advantage when the immune system's down.
Right. We've talked about how to figure out who the culprit is using the patient's history, exam, and lab tests, right?
Like piecing together a puzzle. But now, let's talk about the real battle plan: treatment. How do we actually fight these infections?
Okay, so remember, treatment always depends on which pathogen is causing the problem. It's got to be tailored specific.
Like a custom-made suit, right?
Exactly. But there are some general principles that always apply, especially in immunocompromised individuals.
Okay, remind me, what are those key principles again?
Well, first, got to act fast. Immunocompromised patients, they're more likely to get worse quickly, so early treatment is super important.
Every minute counts, right?
Absolutely. And we often start with broad spectrum antibiotics, the ones that cover a wide range of bacteria, especially when we're not sure what's causing the infection.
It's like casting a wide net to make sure we catch the bad guy.
Exactly. Damage control, right.
Ugh.
Then once we get the culture results, and we know exactly which bacteria it is, we can adjust the antibiotics.
So start broad, then narrow it down based on the lab tests.
Right. We call that de-escalation. Helps prevent antibiotic resistance and minimize side effects.
Makes sense. Anything else?
Oh, and always be careful about drug interactions. A lot of these patients are on multiple medications, so it can get tricky.
Got to make sure everything plays nice together.
Exactly. And don't forget about supportive care. That's crucial.
Supportive care, what does that mean exactly?
It's all about making sure the patient is as healthy as possible while we fight the infection. Oxygen therapy, maybe even respiratory support if they're having trouble breathing.
Right, like giving their body the extra help it needs.
Yeah, exactly. And nutrition, too, making sure they're getting enough calories and nutrients. Sometimes that means dietary changes, IV fluids, or even tube feeding.
Okay, so those general principles.
Yeah.
Act fast, start broad, narrow down the treatment, watch for drug interactions, and don't forget supportive care. Those are key for all these cases, right?
You got it. Now, let's get into the specifics of treating different types of pneumonia.
All right, let's do it.
So, bacterial pneumonia, the most common one. For those usual suspects, Streptococcus pneumonia and the others, we typically use antibiotics like beta-lactams, macrolides, or fluoroquinolones.
Right, the standard antibiotics.
But we always have to consider local resistance patterns, make sure we're using something that will actually work.
Makes sense. So what about those opportunistic bacterial infections, the ones that, take advantage of a weakened immune system?
For those, we need the big guns.
Big guns, like what?
Well, take Pseudomonas aeruginosa, for example. It's notorious for antibiotic resistance, really tough to treat.
Yeah, we talked about that. So how do we fight something that's so resistant?
We have to use combination therapy, using multiple antibiotics that attack the bacteria in different ways.
Okay, so a multi-pronged approach.
Right. We often combine things like anti-pseudomonal beta-lactams, aminoglycosides, and fluoroquinolones. And we use susceptibility testing to make sure we're choosing the most effective antibiotics.
So it's like a personalized treatment plan based on the specific bacteria causing the infection.
Exactly. Okay, now, viral pneumonia.
Viruses, those can be tricky, right?
They can be. For CMV pneumonia, we use antivirals. Ganciclovir, valganciclovir, or foscarnet.
Right. Those work by stopping the virus from multiplying.
Exactly. They give the immune system a fighting chance. And the length of treatment, well, it depends. How severe is the infection? How well is the patient responding?
Okay, so individualized treatment based on the specific situation.
Right. Now let's talk about those fungal pneumonias. We spent a lot of time on PCP, but just to reiterate, the go-to treatment is TMP-SMX.
Right, and starting treatment early is super important, especially for immunocompromised patients.
Exactly. And remember, corticosteroids can be helpful in those moderate to severe cases to calm down that inflammation in the lungs.
It's all about giving the patient the best chance of getting better, using all the tools we have.
Exactly. And for other fungal infections, like invasive aspergillosis, we use antifungal medications, voriconazole, amphotericin B, the echinocandins.
Right, the big guns for fungal infections.
Right. And the specific antifungal, well, it depends on the fungus itself, the severity of the infection, the patient's overall health, and so on.
Wow, this has been so informative. I feel like I have a much better grasp on pneumonia now, especially in immunocompromised individuals.
That's great to hear. Remember those key principles: acting quickly, tailoring the treatment to the specific pathogen, watching for drug interactions, and providing supportive care.
And don't forget about prophylaxis, right? Preventing these infections in the first place.
Oh, absolutely. Prophylaxis can be a game changer, especially for those who are high risk.
Okay, so I think we've covered everything we need to know about pneumonia in the immunocompromised, at least for now.
Medicine is always changing, right? New research, new treatments.
That's what makes it so exciting. Always something new to learn.
Absolutely. So keep learning, everyone. Keep exploring this topic and stay up to date on the latest treatment guidelines.
And as always, this deep dive is just for information, not medical advice. Talk to your doctor for any health concerns.
If you're worried about your health or someone else's, always reach out to a healthcare professional.
Well, that wraps up our deep dive into pneumonia in the immunocompromised. We hope you found it helpful. especially as you're preparing for the MCCQE and getting ready to be amazing doctors.
It's been a pleasure sharing our knowledge with you all.
Until next time, everyone, stay curious and take care of yourselves.
And each other.